And it's a great pleasure to introduce Terrence Holt, who's also an internist, and he's also a writer, and he's from Chapel Hill, down the road. Today's lecture honors Ellis Moore, who started medical school after an early career as a public school teacher. He went on to train in otolaryngology and practice for 30 years or so in New York City. And every year, around the time of the Festival of the Book, Medical Center Hour invites a doctor or medical educator who is also a writer. And Dr. Holt, today's speaker, like Dr. Moore, was a teacher before medical school. And if you read his bio, it reads like the success story of 4 or 5 successful people. Critic, fiction writer, English professor, internist, geriatrician. At dinner last night, we asked him why, relatively late in life, he chose to go to medical school. And his answer, like most honest answers, beat around the bush. And I think it's because in medicine we like differential diagnoses. But there are really no simple answers to difficult questions or why we make life and family-changing decisions. And given the demands of medical school residency and academic life, it never hurts to have lots of good reasons. What he made clear last night, and will share with us this afternoon, is that he loves his work. He's really very good company. I'm not sure at all what the Medical Sublime means, but I'm looking forward to finding out more. Thank you.
Thank you. Can I get your signature on that later? I'd love to carry that around. It's very good to be here. I won't complicate it by saying more. I should warn you, I did make the discovery while printing this out at the Marriott recently that I neglected to put page numbers on it, so if that door opens, this could get interesting, but we'll see what happens. Okay, all right, so. Oh yeah, there. Anybody know what that means?
To be rather than to see.
Very good, very good. It's the motto of North Carolina, and it actually does have some application here. But I'd like to begin with a local boy, Edgar Allan Poe, who, as I'm sure you all know, had to leave here after a semester because he couldn't afford it. The protagonist of his 1833 short story, MS Found in a Bottle, while clinging to life aboard a ship shattered by an enormous storm, encounters this extraordinary vision. A gigantic ship of nearly 4,000 tons. Although upreared upon the summit of a wave of more than 1,000,000 times her own altitude, her apparent size still exceeded that of any ship of the line or East Indiaman in existence. She rose up like a demon of the deep, slowly from the everlasting gulf beyond her. For a moment of intense terror, she paused upon the giddy pinnacle, as if in contemplation of her own sublimity, then trembled and tottered and came down. He jumps aboard this monstrous vessel, only to find himself bound on a death plunge into an enormous whirlpool at the bottom of the world, something that I myself hope to avoid in the next 40 minutes. When that ship pauses, as if in contemplation of her own sublimity, Poe seizes that aspect of the sublime that I want to address today. The value of the humanities to medicine is that it allows us to frame some important questions about our own situation, an immensely powerful institution poised on the pinnacle of its success. What does it mean to imagine medicine that way, to imagine ourselves that way? Are there more productive responses to our success? To some extent, what I want to say in response to that is simple, that the humanities, which articulate such fantasies for us in a way that allows us to critique them as fantasies, is an essential tool for self-knowledge. The premise is simple, but because to be human is to be complicated, understanding the connections between ourselves and Poe's shipwrecked sailor takes some work. The sublime is a much mystified term in the 18th century discourse of aesthetics. Its most complete articulation appears in Kant's 1790 Critique of Judgment, where he introduces it as an antithesis to the beautiful. The feeling of the sublime, he writes, is a pleasure that only arises indirectly, being brought about by the feeling of a momentary check to the vital forces, followed at once by a discharge, all the more powerful, And so it is an emotion that seems to be no sport, but dead earnest in the affairs of the imagination. Hence, charms are repugnant to it. And since the mind is not simply attracted by the object, but is also alternately repelled thereby, the delight in the sublime does not so much involve positive pleasure as admiration or respect, i.e. merits the name of a negative pleasure. This paradoxical attraction or repulsion may arise from the way in which the sublime figures the limits of our powers of judgment, of understanding, the point at which reason gives way to unreason. Unreason figured not as void or chaos, but as overwhelming power. That which, without our indulging in any refinements of thought, but simply in our apprehension of it, excites the feeling of the sublime, may appear, indeed, in point of form, to contravene the ends of our powers of judgment, to be ill-adapted to our faculty of presentation, and to be, as it were, an outrage on the imagination. And yet it is judged all the more sublime on that account. If this seems a bit hard to grasp, I confess I hardly understand it myself. And while the failure of our comprehensive capacity seems to be essential to the concept, in criticism, repeating the gesture of the text rarely gets us anywhere. The challenge of the sublime is not simply to sit back and enjoy the sensation, if it's possible to do that while reading Kant, but to understand why you're having that sensation in the first place, what it's trying to tell you. Not about that enormous ship, the storm, the whirlpool, but about yourself. It may help to situate the sublime historically as part of the Enlightenment response to the breakdown of old ways of understanding the world. With the loss of God, 18th century Europe finds the power of the physical world at once terrifyingly mysterious and compellingly attractive. The awful possibility that we're alone in the world implies our contingency on forces we cannot comprehend, forces intimating ultimately our mortality. The sublime, it is important to remember, is distinct from the phenomena eliciting it. The term signifies our response to those phenomena, a response at once phobic and reassuring to a problem actually inhering within the observer, the problem of embodiment. The problem isn't only with our bodies, but what they embody, the conscious self that is troublingly neither of nor separate from the physical. As part of that consciousness, it is the imagination that makes us susceptible to the sublime, as it leads us to imagine ourselves as what our bodies ultimately prevent us from realizing. Capable of infinite imagination, yet trapped like Ariel in her tree or Caliban in his brute body, our mortality cages us in an intolerable paradox. Any encounter with whatever seems to figure that paradox externally calls forth the response Kant calls the sublime. Classically, we experience sublimity whenever the forces of nature remind us of how vulnerable we are in such an incomprehensibly powerful universe. Part of our response, that discharge all the more powerful that makes the sensation in part attractive, is an attempt to project the self imaginatively out into the infinite inane, to identify with those forces that threaten our identity. But such a response, because it is wishful, unable to change the physical facts that are at the root of the phenomenon, cannot resolve the paradox. It can only repeat it. The projection in its powerlessness, not only failing to achieve our grandiose desires, but reminding us of how far we always fall short of them. The critical discourse of sublimity seeks to recover the self from that projection, to track the ways we externalize what are more properly our own problems. I would like today to extend the project to the world of medicine. I believe medicine is approaching its moment when, like Europe in the 18th century, it will reach the limits of its model for understanding the world. Such moments are the haunt of the sublime. The current model, which has served medicine so well for so long, is a particular construction of empiricism, for which we have to thank primarily Newton, who gave us the tools and demonstrated their power to understand the world in terms of number. And in case you don't recognize him, that is Newton. That's imagined by Blake. He's at the bottom of the ocean. The application of quantitative analysis to the physical world has in the past century extended its reach to biomedicine with spectacular results. In evidence-based medicine, we've seen the flowering of that success, allowing us to know for the first time in history precisely what we do when we prescribe a drug or cut into the body. And as the genome continues to yield up its secrets, that success can only grow. But even in that flowering, we're coming to recognize that counting things can take us only so far. Consider genomics, for instance. As we come increasingly to recognize the role of genetic variation in determining the outcome of our interventions, we find ourselves confronting questions no amount of mathematics can resolve. The genome, in its intimate relationship with the environment, brings us into the realm of human behaviors that are generally understood under the term culture. And that is a realm in which to date, despite the efforts of the social sciences, quantitative analysis has failed to gain the traction that it holds in the biophysical world. In this aspect of genomics, we're only encountering one form of a phenomenon medicine has been grappling with for some time, the persistent difficulty of translating our experimental and analytic success into something that actually helps people. The recognition, for instance, of the difference between a trial of treatment and a trial of the intention to treat tacitly acknowledges that our science must ultimately function in a much larger world of beliefs and practices that have little faith in or use for science. This is the world where people do things with powerful effects on their own health, for good or ill, and in the public sphere with powerful influences over the practice of medicine. I should make clear at this point that I'm not arguing for an abandonment of evidence-based medicine or a rapprochement with the crystal healers. Rather, I think we need to understand, among other things, why millions of people prefer alternative medicine to allopathy, despite the overwhelming weight of scientific evidence in favor of the latter. If we're to be of much use to those people, as well as to the tens of millions more who reject such fundamental precepts of contemporary biology as evolution, depending on who you ask, it's between a third and 60% of the population, we need to understand the rules of the world that they and we inhabit. For this, we need to find something better adapted to the question than regression analysis. Even as we are making our first forays into the disciplines which take culture as their object of study, however, we come up against a familiar devil, the tendency embodied in the sublime simply to respond to the sensation by externalizing it, mistaking the projection of our anxieties for their source. Given a choice, we would much rather do something than analyze our role in it. And doing things generally requires some external object to do them to. That preference for the instrumental, the assumption that the proper function of knowledge is to do something with it to somebody else, is part of our DNA. It is so pervasive that we can find it in the most unlikely places, such as the narrative medicine project pioneered by Dr. Rita Charon at Columbia University. This is a movement, I should point out, with which I happily identify. In fact, I didn't realize I carry in a bag with the program's logo on it. It's been enormously helpful to me in my own work. And I think it holds enormous promise for the profession in addressing the problems that I'm discussing here. I'm picking on it now because its susceptibility to those problems demonstrates what we're up against, the kind of thing that goes on in the conceptual blind spot that each of us carries around with us every day. Dr. Charon has, for the past 20 years, been urging us to think narratively. By this, she means that we need to start paying attention to the ways in which the single most important diagnostic tool we have, the patient interview, is structured by conventions drawn from literature. Those conventions shape the patient's story. The ancient narrative traditions that we first encountered in fairy tales and continue to revisit lifelong in other forms constitute a medium, literally a culture medium, in which our beliefs and behaviors grow. The primary ingredient in that medium is a messed up compound of desire, fear, guilt, aggression, and much else we're generally reluctant to recognize in ourselves, but which determine our actions at least as powerfully as evidence and reason do. These traditions are powerful in shaping not only patients' histories, but also our responses as we listen to them. Fortunately for us, stories also offer us an opportunity to analyze and understand those responses. This is the central premise of narrative medicine. What's interesting about narrative medicine, however, is that it didn't stop there. In medicine, as we know, analytics are never enough. Even in its earliest formulations, we find the claim that the narratively informed physician is not only better equipped to understand the clinical situation, his patient's and his own, but will, through that understanding, be moved to respond effectively to the patient's needs. Understanding must become intervention, a telos that, like most, is probably determined more by wish than by experience. Another inflection of narrative medicine is the proliferation of medical autobiography and writing doctors generally, a growth industry that seems to have arisen alongside narrative medicine, but is now so identified with it that to many people, narrative medicine simply refers to narratives by doctors. This boom in narrative medicine both asserts and attempts to evade an important quality of narrative that we, with our predilection for the instrumental, tend to miss. If narrative is a tool, it has its own tropisms, a powerful bent toward inward contemplation, the confessional, which limit its use in conventionally instrumental ways. This is not to derogate this contemplative aspect of narrative. Rather, it is to note and caution against the insistent tendency to think that creative activity must generate a product one can use on others. If the arts are a tool at all, it is one most usefully applied to oneself, and the product of that application is primarily self-knowledge, the point from which any reconnaissance of the human must begin. Toward that end, I'd like to consider the narrative medicine movement itself, at least one exemplar of it, particularly the way it has enabled so many doctors to publish out of the confessional as a cultural text. My discussion invokes Coleridge's Rime of the Ancient Mariner, not because it has anything to do with medicine, but in which narrative confronts the sublime in a demonstration of the ambiguous power inherent in narrative. The capacity of narrative to arrest its audience, to make us attend, and anybody who's read stories to a small child knows exactly how powerful that is, frames the Rime of the Ancient Mariner and famously shapes its fantastic tale of alienation and redemption. But there is another quality of narrative that occupies the central role in Coleridge's tale, a compulsion not to listen, but to speak. The mariner's curse, which outlasts his redemption, is to tell his tale endlessly. Neither he nor his audience, it seems, has any choice. The Mariner is a worst-case demonstration that narrative is not simply an instrument we may choose to apply. It is larger than that, constituting us far more than we implement it, and in that constitution implicating aspects of ourselves and narrative that speak to incompleteness, alienation, loss, and division, at least as much as they conjure empathy, connection, and organic unity. If one tendency in the narrative medicine movement has been to offer narrative as a cure, the disease, as Coleridge also diagnosed it, is alienation. Through narrative, we are told we can connect or reconnect with our patients, our vocations, and ourselves. But do stories really or only connect us? Are there ways in which our narratives also estrange us, if only by offering illusions of connection, or satisfying our desire for connection a little too neatly? Consider Coleridge's Mariner. Consider. He is under a curse. For what? We know quite well. He shot the albatross. Why he shot the albatross, of course, we never learn. It's clearly beside the point. It functions as a given. The arbitrariness of the narrative at that crucial point speaks to the mariner's compulsion to narrate, also unmotivated, which this act is supposed to explain. That it explains nothing suggests we need to look elsewhere. What does it mean to speak compulsively? At once masterful, seizing his audience with a single gesture, he holds him with his glittering eye. The wedding guest stood still and listens like a 3-year child. The mariner has his will. And overmastered, speaking under extraordinary duress. Forthwith, this frame of mind was wrenched with a woeful agony, which forced me to begin my tale. In the moment when the mariner first feels the compulsion to speak, he suggests that his identity depends upon his story. In response to the mariner's plea for forgiveness, the hermit demands, I fell behind. Say quick, quoth he, I bid thee say, what manner of man art thou? In the structure of the rhyme, it is actually this moment, not the death of the albatross, that is the actual starting point of the endless tale. The point from which the mariner begins to reconstruct himself not as a lost sinner, but as a storyteller, not returned to communion with the world, but doomed to haunt it as a strange and monitory figure. The shooting of the albatross is unsatisfactory because it explains nothing. How much more satisfactory can the response to the hermit's question ever be? What manner of man art thou? If the mariner's tale is an answer to that question, it resolves nothing. As soon as he ends his tale, he must begin it again. This very insufficiency tells us something vital about the relationship between story and teller, another sublime relationship that Jacques Lacan identified when he described the ego as a story we tell ourselves to cover over a sense of inherent insufficiency. It is a story that has to keep being told because, being so much more coherent than that deficient self, it only reinforces the sense of inadequacy that drives it. Seen in these terms, the mariner's story is everyone's, but I think it applies particularly to medicine. We feel estranged. We did something unspeakably nasty during the first year of medical school, and to this day we don't really know why. We consorted with decaying corpses and 1,000 other slimy things, and unforgivably we live on. And now all it seems we can do as a profession is go on endlessly about ourselves as if we have no choice in the matter. But to confuse an object such as a cadaver with the source of the medical compulsion autobiography is to miss the point. The point again is not the object, but our response, particularly the way we attempt to identify with what threatens us. We find this logic at work in a well-known story by Oliver Sacks, The Lost Mariner. It tells the tale of Jimmy G, a sailor cursed by the inability to consolidate experience into memory. Jimmy raises for Sacks the same question the hermit asks the mariner. Do you think he has a soul? The question arises at the crisis of his account when Sachs recognizes a therapeutic failure. Feeling the emptiness of Jimmy's inner life, he had not complained of loneliness, but he looked so alone. He never expressed sadness, but he looked so sad. He puts Jimmy to work as a typist. But this intervention, at first apparently successful, in Sachs's account transposes the question about Jimmy's subjectivity onto Sachs. This was superficial tapping and typing. It was trivial. It did not reach to the depths. And what he typed mechanically. He could not hold the thought, the short sentences following one another in a meaningless order. As the mimetic style suggests, this is, of course, Sachs's reading, written over the blank he sees in Jimmy. That the meaninglessness of life without narrative continuity is figured through the act of typing, understandably generates in Sachs's narrative a moment of sublimity. It is at this point that he is moved to ask if Jimmy has a soul, seeking to displace his anxiety, the possibility that he, too, as he writes, might be merely superficially tapping onto the awful void he reads in Jimmy. But by this point, the identification has been made, and the narrative responds to anxieties about its own status by an increasingly compulsive hijacking of Jimmy's tale. Here is Jimmy at Holy Communion. I was moved, profoundly moved and impressed, because I saw here an intensity and steadiness of attention and concentration that I had never seen before and were conceived him capable of. He was wholly held, absorbed by a feeling there was no forgetting. Then, nor did it seem possible or imaginable that there should be, for he was no longer at the mercy of a faulty, infallible mechanism, that of meaningless sequences and memory traces, but was absorbed in an act of his whole being, which carried feeling and meaning in an organic continuity and unity, a continuity and unity so seamless it could not permit any break. And that's the emotional high point of the story. Sachs resolves the fearful emptiness that Jimmy's amnesia reveals by invoking art. Only connect, he reminds us, offering one of the great touchstone phrases of modern literature, making meaning out of emptiness, shaping a case history into something far more coherent and meaningful, and so integrating his own narrative with something larger, identifying himself via Jimmy and the ghost of Forster with art, at least. The trajectory of Sachs's essay explicitly offers narrativist connection, but demonstrates the contrary, falling short not only of communion, but even coherency. Sachs ends his essay with a poignant anecdote about a different patient. He gives a brief history of another amnesiac, who, whenever his wife brought him from a brief visit home back to the long-term care facility where he actually lives, would scream, terrified and confused, "What in the hell is this place? What the hell is going on?" These screams were almost unbearable to watch, Sachs recalls. Concluding that, for some patients, time has come to a stop. Sachs's narration shifts at that moment, arbitrarily, from past, which it's been in throughout, to present tense, as if to mimic the patient's situation. I hear him screaming for a past which no longer exists. But what can we do? Can we create a time capsule? A fiction? And with that question, which goes so directly to the heart of the uncertainties underlying Sachs's account, the essay strikingly falls apart, the final sentences wandering entirely off the topic, gesturing inconclusively to other essays in the volume, comparing this patient to that patient, rhetorically and syntactically surrendering the closure that ideals of narrative coherence usually demand. In identifying himself with the patient, Sachs's narrative wrecks itself formally, demonstrating a capacity in narrative more self-destructive than otherwise. Not entirely, however, but the difference is also instructive. When the narrative ends, it leaves us the task of picking up the pieces, which we happily do, which I'm doing right now, retelling Sachs's fractured narrative, making it over into something different, but for me at least, satisfyingly whole. At least I know what Sachs was up to. I can tell myself. But by this point, the exercise has taken on some hollow echoes. If the only way to shape a whole narrative is to expropriate it in an essentially hermetic gesture, we are still fallen far short of communion. As writers, as readers, as doctors and patients, we inhabit a discourse shaped time and again as narrative, because it seems we have no choice. We create order and integrity out of chaos and loss, using narrative because that is what narrative does. But the construction is always incomplete, tentative and temporary. It betrays and consoles in equal measure, demanding our eternal return to the work of building, of imagining what we might be if we were other than mortal. And this may be, if there is a communion to be had in art, where we finally connect, not in the story, not in the object, for the object is never the end, but in the reading, where we share the task of making stories where might otherwise be simply devastation, not because we want to, not because we delight in our power as readers or writers, but because we really have no other choice. One need not write autobiographical essays in the manner of Sachs, of course, in order to learn about oneself. For most of us, the analytical methods of the humanities serve the same end. The understanding toward which that analysis strives is not really, as we generally assume, an understanding of culture, of how art works or in others, so much as of how art works within oneself. And it's on this point I'd like to offer a final demonstration of the difference between what belongs to us and what we imagine belongs to others that is at the heart of Kant's analysis of the sublime. As a geriatrician, I struggle from time to time against an irritating assumption, common enough among my colleagues in other specialties, that what geriatricians chiefly do is palliate the dying. The geriatrician bristles at this and feels it as a slight. Worse, equating old with dead is a slight to our patients, who in their sheer liveliness are a continuous source of delight. My patients face, as all of us do, the task of getting through each day in the expectation that there will be a tomorrow. How much harder must this task become when one inhabits a culture that thinks of you as already dead? The distinction between the living and the dead is one of the few absolutes I know. It's the only endpoint I respect in clinical research. To confuse that distinction is delusional. And to set a group of people, any group of people, outside the category of the living has terrifying implications. Old. The word is, of course, ancient. It has its cognates all over Europe, tracing back ultimately to the Proto-Indo-European root al, to grow, nourish. Evidently, originally old were simply parents, significant insofar as they reared the next generation. It was only when people stuck around long enough to see their role as child rearers taken over by another generation that a new terminology became necessary and old became something else, in Greek, gerios, in Latin, senex, which may mark the point at which the word becomes problematic. We think a senex is demented because dementia happens to the old. This seems a material fact, stubbornly interfering with well-meaning attempts to imagine old in less disturbing ways, such as our golden years. On the register where words acquire meaning, it doesn't really matter that the vast majority of people over 70 are not demented. The association of aging with dementia sticks because of something stronger than such facts can argue away. What cements it there? On the crudest terms, old is what happens to you just before dead. But the association goes beyond metonymy. There's a powerful tendency to think of life as development. On this register, dead is the telos of old. That's why we have old, in order to be dead. But I think there's something more going on here than teleology as well, important to understand for what it tells us about the limits of our abilities to control our own perceptions. I'd like to consider the relation between two texts about old, for the light they shed on what it means that old shades so irresistibly into dead. King Lear has long been read as the supreme expression in English literature of the myths we tell ourselves about aging. It poses against those myths the absolute reality, the absolute quality of the factual in hearing and death. She's gone forever, Lear howls, cradling Cordelia's body in his arms. I know when one is dead and when one lives, she's dead as earth. Thou'lt come no more, he cries, asserting the full weight of no more with that shattering series, never, 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 never. 2.5 lines later, as if to confirm the finality of this recognition, Lear joins Cordelia in death. But that moment, interestingly, is obscured. Edgar cries out instead, he faints, and implores him, look up, my lord. For the climactic moment of a play so invested in death, cushioning the blow in this way is odd. It is especially so in light of the play's other central interest in truth-telling versus dissembling. In knowing the difference between what is, such as Cordelia's fidelity or Edgar's or Kent's, and what merely seems, the counterfeit affections of Regan, Goneril, or Edmund. At the crucial moment of Lear's death, the two themes collide. Death is held in suspension as Edgar misrepresents it to the audience. The uncertainty is brief. Kent corrects Edgar immediately, but this is not the only such moment. Lear himself can say about Cordelia, she's dead as earth, and in the same speech, lend me a looking glass. If that her breath will mist or stain the stone, why then she lives. Look on her, look her lips, look there, and still calling us to look, Lear dies. Why does Lear die asking us to look? It has something to do with the way Kent and Edgar respond to the appearance of this old man carrying Cordelia's corpse. One asks, is this the promised end? Doomsday. The other adds, or image of that horror. What is the difference between the promised end and its image? At this point in the play, it seems an odd question, but if it is odd, it is an oddness the play goes out of its way to underscore in Lear's uncertainty as well as in Edgar's over the one fact that seems as far beyond doubt as it is beyond such distinctions as promised end or its image. Or perhaps not. The full import of the question is easy to overlook, but is this the promised end or image of that horror actually goes to the heart of the play's concern with appearance, with the difference between looking and seeing, seeming and being, and finds there one explanation of our own pervasive blindness to what should be obvious. Of course, this isn't doomsday. We're watching a play, the image of that horror, a play, moreover, that is about to reach its promised end. The answer to the question is, inevitably, it's both. The play insists on a quality of narrative that is vital to understanding not only the play's moral universe, but the question that we're considering today. Everyone in Lear dissembles. Everyone presents an image that in its difference from what we might imagine as the thing itself generates the action of the play, and the play itself as performance. The actors are lying to us too. It's hard to remember that, but they are. Had Regan and Goneril not lied about their loves, had Cordelia not coyed hers, it's difficult to imagine the action proceeding as it does. No one is above duplicity. Kent and Edgar are as false in their way as Edmund is in his. Gloucester, in his moral idiocy, is all too willing to participate in reifying Edmund's lies. Lear fools himself, and in presenting his ironic commentary as foolishness, the fool dissembles most of all. Edgar's closing apothegm, speak what we feel, not what we ought to say, suggests that these lies all rise out of some tangle of social obligation. This is certainly what trips up Cordelia. And while this is important, the central point on which the curtain falls is personal integrity, in being, not seeming, in knowing and maintaining the crucial distinctions on which life ultimately depends. Appearances deceive, confusing what should be kept distinct as fatal. If Lear's and Edgar's confusion in the final scene tells us anything, it's that such confusions aren't only fatal, they're also wishful. Our misprisions on some level protect us. Their persistent repetition from both Lear and Edgar, especially Edgar, who in the play's closing speech seems to become our access to the truth, suggests that this desperate wishfulness is at best very difficult to escape. It is, in the end, stronger than the incontrovertible facts of first Cordelia's and then Lear's deaths. In this final turn, the play addresses not only truth and deception, but the relationship between perception and imagination, those things we see because we will ourselves to. This is not, we are reminded, the promised end, but only its image. We're watching a play. The entire illusion ought to come crashing down around our heads at that moment, but of course it does not. We go on, gripped by the spectacle of Lear's suffering, despite everything we know to the contrary about what is and what merely seems. In that moment, it is the seeming that takes on the greater reality, utterly convincing in no small part because so utterly sad. King Lear offers here an analysis of the sublime, showing us how powerfully an affective response determines, via the imagination, our relationship to the world around us, especially in its destructive aspect. In part. There is another aspect of Lear's tragedy that complicates the situation, insisting on the ways those affect-laden responses attempt to enforce a vision of the world in which its destructive energies turn on anyone but ourselves. Consider just whose play is Lear. The title suggests it's Lear's story, but the action tells us otherwise. It is true that Lear's retirement turns out badly, but whose fault is this really? Not every foolish parent necessarily makes himself the object of parricidal lust, or at least so I tell my children. If the entire action had followed Lear's intention, King Lear would be a very dull play. But it is the young, not the old, who determine the play's action, through the elaborate machinations that begin with Goneril's first speech. This essential fact about Lear is important enough that the play reiterates it endlessly and distributes responsibility for it widely. Cordelia, in hiding her love, dissembles to even worse effect than Regan and Goneril. And Edgar, in conducting his blinded father through a fantasy about his miraculous fall and survival, is given the most stagey role of all, identifying the young not just with craft, but stagecraft. Edgar's ruse aligns him directly with the machineries of the plot. The moral division of truth versus falsehood is carefully mapped not over good and evil, victim and agent, audience and speaker, but persistently over old and young. The machinery of this play belongs to the young, explicitly to the children of aged parents, shaping events to their own ends. They shape events specifically by shaping perceptions. Regan and Goneril create the perception that Lear is senile. Edmund shapes Gloucester as a traitor, and Edgar convinces his father that he is a miraculous survivor, really, in this play, the cruelest deception of all, using him for the wanton gods, that is, in the language of Shakespeare's theater, for the audience's sport. In Act 1, Regan and Goneril tell each other a story about age in order to provide an occasion for their treachery. They shape this narrative with an eye to public perception. That you should protect this court, she tells her father, and put it on, should not scape censure, nor the redress of sleep, which, in the tender of a wholesome weal, might in their working do you that offense, which else were shame. Children in Lear construct age in terms familiar to all of us, constructed explicitly as public discourse, shameful, needing to be put away. Shaping the audience's reception of the play, even as they shape the plot, the ease with which this construction of old goes over, our willingness to see Lear as a mad old man, senile and doomed to death from the first scene, reflects in turn our own comfortable familiarity with its premise. King Lear is very much a story about presentation and perception, about stagecraft and audience, about writing and reading. And it's in this last aspect that it generated, more than 2 centuries after its first performance, a gloss not on the play itself, but on the act of reading it. This gloss is Keats's sonnet, known as On Sitting Down to Read King Lear Once Again. And I should point out that John Keats, at this time, had basically just dropped out of medical school to be a poet. He'd been studying medicine. He was a surgical dresser at King's College at Guy's Hospital, in London, up until just a few months before he wrote this poem. Composed on or about January 23, 1818, when Keats was 22 years old and 3 years away from his own death, the poem appears in a letter to his brothers in which he reports, I sat down yesterday to read King Lear once again. The thing appeared to demand the prologue of a sonnet. I wrote it and began to read. I know you would like to see it. O golden-tongued romance with serene lute, fair-plumed siren, queen of far away, leave melodizing on this wintry day, shut up thine olden volume and be mute. Adieu. For once again the fierce dispute twixt hell torment and impassioned clay must I burn through. Once more essay the bittersweet of this Shakespearean fruit. Chief poet and ye clouds of Albion, begetters of our deep eternal theme, when I am through the old oak forest gone, let me not wander in a barren dream, but when I am consumed with the fire, give me new phoenix wings to fly at my desire. The poem begins with a command to shut up. This is not out of character for Keats at this point in his career. After the disastrous reviews of Endymion, he'd been working hard to stifle the romantic strain in his work in favor of something more serious. Rereading Lear was a part of that project. But the language also echoes Keats's most celebrated silence, upon a peak in Darien, where he imagines himself falling mute in the face of the poetic tradition. When the end of the second quatrain in the Lear sonnet finally named Shakespeare, we realized we were back in those same realms of gold. Except this time, we're in hell, surrounded by tokens of the fall of man. The mean we're entering are held not by Homer, but by Shakespeare, Milton, Dante. The speaker's prayer, not surprisingly, is that he not be lost in that company. The barren dream and the adieu have their echoes later in a similar apostrophe to a nightingale, and carry here the same burden, a fear of meeting an unproductive dead end, a fear allayed partly by a turn to an image that suggests fantastically, wishfully, the possibility of escape. Escaping traps is the master trope in Keats's work, from sleep and poetry to that undead hand reaching out at us from the margins of a page. Evidently about the last thing he wrote was in the margins of another manuscript, and it reads, this living hand, crap, I can't remember. But anyway, it threatens the reader with the idea that his dead hand, explicitly dead, is about to reach out through the page and grab you. It's one of the creepiest marginal comments I've ever seen. What dead end is he facing there? We know, of course, how anxiously this generation regarded Milton. How much more anxious, then, is this poem, which raises the ante from his earlier encounter with Homer to put the speaker up against not only Milton, but Shakespeare and Dante. This sonnet appears at a critical point in Keats's career, the beginning of what critics call his annus mirabilis. Within 4 months of the date of this poem, he had written all 6 of his great odes at the age of 22. But it is also not long after Endymion had been trashed by Lockhart and Blackwoods as imperturbable, driveling idiocy, recommended he go back to his bandages and ointments. The charge of idiocy evidently stung because much of Keats's rumination in this period involved seriousness in one form or another, and the difficulty of grafting that onto the passionate sensuality that he understood as his métier. So more than any other poet of his generation, by the time this sonnet appears, Keats was setting out explicitly to challenge Milton on his own territory with an epic retelling of the Fall. It's no wonder he approaches this terrain, this scene also of Lear, so uneasily. But there's more than poetic reputation at stake for Keats and Lear. In a letter to Benjamin Bailey written the same day, Keats reports, "My brother Tom is getting stronger, but his spitting of blood continues. I sat down to read King Lear yesterday and felt the greatness of the thing up to the writing of the sonnet." Bang, bang. It is not surprising that a report of Tom's spitting of blood would lead by immediate association to King Lear. But there are other items in Keats's correspondence at that time that both widen and specify the association. A month earlier, he had written, "I went to see death on the pale horse." It is a wonderful picture when West's age is considered. I think West was 78. But there is nothing to be intense upon, no women one feels mad to kiss, no face swelling into reality. The excellence of every art is its intensity, capable of making all disagreeables evaporate from being in close relationship with beauty and truth. Examine King Lear, and you will find this exemplified throughout. I can't remember the last time I got an email that talked about this kind of thing. West's Death on the Pale Horse draws its title and subject from Revelation 6:8. "And I looked, and behold, a pale horse, and his name that sat on him was Death." Death is a little hard to make out. He's that really dark and spiky guy up there. In the iconography of the apocalypse, the pale horse is traditionally associated with plague. In Keats's time and since, specifically with tuberculosis. Not the promised end, perhaps, not yet, but its image. What King Lear seems to threaten Keats with is simply death, in the form most familiar to Keats at that time, the consumption with which his brother was already burning, the consumption, by the way, that is the active verb in the last line of the Lear sonnet, and which would consume him as well. Keats writes, of course, in anticipation of the event, and as if to forestall what he knows is waiting for him in that old oak forest. Whether the death he fears is merely of his poetic reputation or his actual death doesn't really matter, the epitaph conflating the two. "Here lies one whose name was written in water." He wrote it before his own death. Is his last word on that question. The sonnet's final image, converting consumption into the fire through which the phoenix finds itself reborn at my desire, figures what is already implicit in the preceding couplet and in the poem itself. The fire is still the hectic flush that marked consumption's victims at the stage Tom was passing through. Those phoenix wings seem to offer escape, but they do so in terms that already question the possibility. The image comes directly from that realm of romance he's trying to leave behind. And the phoenix, of course, rises from its own ashes only to burn again in another of those endless cycles of life and death the romantics were so fond of. The poem's last words acknowledge the element of wishfulness in all of this, because wishful it is. Confronted with the greatness of Lear, Keats turns away to write about himself and his poetic ambitions. That the poem cannot entirely efface what he fears is the fate of all such gestures. The turn away is also inescapably a turn toward. But in figuring that turn in the terms he does, terms he begins explicitly by rejecting, Keats acknowledges and allows us to see that what we cannot escape, we may at least critique, putting a distance between ourselves and our desires for immortality that points to an alternative to the rejective trap of the sublime. What Keats offers us here is a critique of what happens when we read King Lear, when we read Old. Just as the speaker in this poem can't help but see the play as a portent of his own death and so must rewrite it into a happier, avowedly wishful autobiography, when we look at Old, we cannot help but see in it our own deaths. There's no escaping the association. The most we can hope for is to know that when we make it, it is not our elders, but our own end we see there. It is in our recoil from that impossible image that the whole concatenation of dissembling and recapitulations begins. The abjection that demands Old be not us, be something entirely other, death itself, above which we must soar, because we, of course, we are not Lear, we are not Old. The young Keats, with more reasons to know and to fear death than many other people, cannot escape this fantasy. But all those reasons also mean that he can name it as a fantasy. We imagine that We regard age and death from a safe distance, but in that distance, inevitably, things blur and merge in a collapse to the sublime at once consoling and terrifying. Why does Lear die calling on us to look? Because old is all about looking. It is in our refusal to know that what we see in those older than us is a projection of our own mortality, not the accomplishment of theirs, that the damage begins. To those elders whose lives are diminished, and to us, as that diminishment reduces us as well. As it approaches the limits of its power and knowledge, medicine has a chance to follow the path Keats points for us, not into a fantasy of endless power, but toward an acknowledgement that there are other ways of knowing who we are in relation to the forces with which we struggle. Doctors need such a mirror more than most because our being in the world impinges so powerfully on others. Even more than knowing our science, our practice, or our patients, we need to know ourselves. Thank you. And I imagine there might be a question or two.
Thank you very much. I mean, I'm still thinking about how dry ice gets to gas and sublimation, so there's a lot to follow. Just to sort of re-engage with the topic of narrative medicine, and something we talked about last night at dinner, the idea of the doctors writing in confessional mode and kind of appropriating the patient's story as theirs. What's wrong with that?
You know, it's funny, that question has come up repeatedly. The letters to Gemma after Rita Sharon's first articles, they were nuts. They accused her of basically being a godless communist. It was quite interesting. But there was real fear in the profession when Rita started talking about narrative, that there was some kind of moral and epistemological relativism being, trying to sneak into our world of logical positivism. And after that, there came a similarly kind of outraged and very moralizing response directed at doctors writing about the medical situation. A lot of this comes out of the illness narrative community, the patient advocacy community, which I think not unreasonably worries about doctors consuming all the oxygen in the room. Oh, is this turned on? Can you all hear me back there? But you're trying to record it. This is my attempt to escape YouTube. There, can you hear me now? Okay. I don't know how that got turned on. There is this sense that we shouldn't reveal too much of what goes on in medicine, and to some extent that's absolutely right. The last thing on earth you want is to hear your internist thinking out loud, at least in the early going of the differential. And of course there are entirely, not just reasonable, but imperative concerns about protecting patient privacy. All of which makes writing autobiographical narrative from the perspective of the doctor complicated. And yet, I think it's a story that really needs to be told for a lot of reasons. One, we need to tell it. I think the world at large needs a much more realistic perception of medicine than it has now. There's no guarantee that when we write about ourselves we're truthful, but there's a chance there. I mean, how do most people in our country know what goes on in hospitals? It's a terrifying question. I have a hard time watching the doctor shows on TV, but when I flip through them when I'm channel surfing, they're just bizarre. And even though they have great consultants, they're clearly struggling to get the facts right. Every instant is tonally wrong. I mean, if I found myself working next to people who carry on the way people do on TV, I'd be deeply worried. And yet that's how people understand medicine in our country. So I think it's a story that needs to be told. And anytime there's two people in the world, there's two stories to tell. it would be wrong for the doctor to presume to tell the patient's story. That would be really wrong. But I think it's just as wrong to say the doctor cannot tell the medical story. So that's how I justified my own practice. I'm pretty content with it. Yeah.
Hi there. Hi there. Thank you for the talk. I'm Andy Sutherland in neurology. I think I heard somewhere in there something along the lines of when you were talking about old and death. The perspective of a geriatrician, that somewhere along the lines of the outcomes that you care the most about in clinical research are life and death. It's something along those lines.
In clinical trials, really, that's the one that you can't fudge. I mean, I hate these studies where you get multiple endpoints and, chest pain and things like that, which are really nebulous. I like trials that take mortality as the endpoint. It's hard to cheat on that one. That's all. I was raised in a very skeptical school of evidence-based medicine.
Sure. No, I think obviously as sort of a pseudo-geriatrician, as a stroke neurologist, disability and quality of life following stroke is assumed to be a maybe more appropriate characteristic outcome of stroke per se than death. But it brings up an interesting point, in how we measure that. But then also relating back to your talk, sort of how do we weave in the narrative into sort of the sterile environment of clinical research, I suppose.
Well, yeah, that's a great question. How do we measure quality of life? God help us, there are instruments out there that claim to produce quantitative assessments of quality of life. This makes my blood run cold. I mean, this should be a self-evident proposition that cannot be done, and yet we do it all the time. It's important to bear in mind why we do it. I think it's great that we try, because it means that we move beyond that blind, let's keep the patient alive another hour just because we can. And thank God we move beyond that. But just because that raises really troubling questions, like how do you know when it's time to withdraw support, as we say, doesn't mean that the answer is to create an entirely delusional appearance of objective truth out of some numerical instrument. What it means is you have to do the really hard work of trying to figure out what the right thing is for that person and that family in that situation. And a lot of that is understanding that you've always got a dog in the fight too. And knowing where that dog is and how to leash it is absolutely vital. Otherwise, you're going to go into those conferences with families and just make a lot of suffering for everybody, including yourself. But that's where, this is where the old clinicians like to say, well, there's the art of medicine. And by God, I think they're right. You cannot reduce that to any kind of quantity. There's no algorithm that's going to steer you through that one. I think where you learn how to do that is by experience. And one way to get a lot of experience with people's most important, deeply held, inmost desires, fears, etc., is through literature. It's a great source of experience, especially through the reading of literature, where what you're actually coming to understand is your own responses to these things. And that's what you really need to know. I know that I weep helplessly whenever I read King Lear. It's an important thing to know because it keeps me from making complete ass of myself when I have these consultations with families. But there's probably more serious benefits to be had. But finally, I think what we need to do is to understand that we're always part of the equation. Our understanding of ourselves is never, ever, ever going to be reducible to any kind of simple method, but that we do have in the humanities really well-developed technologies, if you will, for acquiring that kind of knowledge. There's a numerical scale of empathy too, by the way. It's a validated instrument.
There's also a functional MR.
Oh yeah.
Pain
yeah.
signature.
Yeah.
That so you can look at the MR and see what's happening maybe in the mind or in the brain at least.
It's lighting up in all those pretty colors. Yeah.
But we were interested in this topic doing a paper on mindfulness, and it's mindfulness-based stress reduction for chronic pain, and some of that research makes a distinction between pain and suffering. And so,
yeah, there's a long literature on that. Yeah. Well, you mentioned functional MR, and that's one reason why I'm so happy to be practicing medicine. I liked when I was a literary critic, but it's more fun to be doing literary criticism as a doctor. All this stuff that I've been talking about ultimately arises out of, this awkwardly material stuff in here. We have no idea how, and yet there it is. There's the central problem. How do you negotiate between the physical world and that which arises from it? These epiphenomena that we think of as ourselves, among other things. You can't ever entirely disentangle the two. But it's really important you're not confuse the two either. And again, that's something that just requires an enormously well-informed, careful, tactful, nuanced assessment at every step. To think that the fMRI lighting up in certain places tells you that, is there a surgical procedure to get rid of people's empathy? Good for the military. We jump so quickly from poorly understood observations to again, the instrumental response. That we're still scratching the surface of a lot of the really, really important questions in medicine, which is one of the things that makes medicine just so incredibly absorbing.
thank you very much. I'm not sure what the medical center hour is going to be next week. Shelley, do you have the schedule?
Yeah, it's animated skeletons in the history of distraction. The speaker, yeah, I can't pronounce that, sorry.
Okay. Well, come back next week.